Hello and welcome to the Becker's webinar around reducing the environmental impact of anesthesia gases with real-world EMR data. My name is Dr. Rowland Illing. I am the Chief Medical Officer and Director of International Public Sector Health at Amazon Web Services. So I'm responsible for healthcare outside the US. I'm also an academic interventional radiologist and still faculty at University College London. I'm delighted today to be joined by two very eminent guests who are both experts in the field of both healthcare, technology, and sustainability. We have Dr. Elizabeth Hansen, Liz, founder of Project SPRUCE Forest, assistant professor at the University of Washington, and is a pediatric anesthesiologist at Seattle Children's Hospital. And we also have Dr. Dan Lowe, the Chief Medical Officer of AdaptX, who is also an Associate Professor at the University of Washington and also a Pediatric Anesthesiologist at Seattle Children's Hospital. Thank you both for joining us.
Thank you.
Thank you, Roland.
Perfect. So this is a really interesting area. There's a huge movement at the moment around sustainability more broadly and ESG. And healthcare sustainability is becoming a really important talking point. And we see it both from clinicians who are interested in the environment, organizations who want to reduce their carbon footprint. And interestingly, more and more, we're seeing it actually in tenders. So tenders going out to organizations saying, how are organizations going to overall reduce their carbon consumption for the long term? So I'm delighted that we have a real focus here on both the clinical and technology crossover. So maybe I'd like, Liz, could you first of all, I'll pass over to you, and really, how does healthcare impact on climate change? That's a question I'm sure a lot of the viewers will be sort of interested in. What is the impact, do we believe, on the climate?
Yeah, absolutely. Well, healthcare is, utilizes a ton of resources and energy and is responsible globally for about 5% of total carbon emissions worldwide. In the United States, where I practice and where I live, we emit 25% of those global emissions, and it's about 8.5% of the national emissions. So this is a really huge source of emissions and pollution. And unfortunately, this is directly contributing to disability and mortality among our populations. So this is a serious problem, and it's something that as clinicians and folks working in healthcare, we can actually do something about, and it will have a beneficial effect on our patients and our communities.
Fascinating. And so, I mean, the fact that healthcare is the 5th largest carbon emitter on the planet is really striking. And so I totally agree. These are social determinants of health almost. These are this is the indirect impact on healthcare of those all around us. So what is exactly the scale of this problem? How do we actually contribute as healthcare workers and healthcare organizations to the climate crisis?
Yeah, so I think it's pretty obvious if you're working in healthcare, you look around and see all of the materials and resources that go into delivering healthcare. Dan and I are pediatric anesthesiologists. We work in the operating room and we see every day, these massive bags of waste, and some of it's recyclable, some of it's not, but all of that is leaving the operating room after every case. So we see the visual of how much material goes into delivering care in the operating room. What we don't see though is the energy used to fuel all of the equipment that's used in surgery and anesthesia. And we don't see the inhaled anesthesia gases that we're using. They're invisible, but they are massive sources of emissions because they are all potent greenhouse gases. So there's the visual of, just all of the materials that we see, but also the invisible of the energy usage and the emissions and pollution that we emit that we can't see.
Fascinating. So there are different elements here, aren't there? There's kind of a supply chain and transport piece to get all of the goods to and from hospital and to keep things available at the point of need. And then there's that single-use aspect to it that I think is everywhere in healthcare. Now, everything's plastic and disposable for hygiene reasons, and that kind of the whole way of reusing healthcare supplies has kind of gone by the wayside. the energy consumption is fascinating because, again, we're very focused on that with regards to cloud computing and moving off physical infrastructure because it's just more efficient. And then you've got clinical operations themselves and the things that we do to provide healthcare, such as anesthesia, which also has the impact. So is that a good way to look at it? So the supply chain piece, the energy and infrastructure, and then clinical operations?
Yeah, absolutely. And sustainability experts actually do inventories of this, and they look at what are called scope 1, 2, and 3 emissions. And what we started focusing on is, some of the scope 1 emissions. These are direct emissions. So this is, when our anesthesia gases are emitted out of the hospital, they are equivalent to, carbon dioxide equivalents going out into the atmosphere because they are potent greenhouse gases. And so one of the things I learned when I started looking into the literature on this topic is some of our anesthesia gases, like desflurane, one of a used to be pretty commonly used anesthetic gas, and in some places still is very commonly used. One bottle of desflurane would be equivalent to burning almost 1,000 pounds of coal. So these are really potent greenhouse gases. And that's part of our direct scope 1 emissions as a hospital.
That's incredible. That's incredible to understand that the operating room can be such a potent source of carbon emissions. And just out of interest, how long has this been known for? Because again, presumably people have been using desflurane for some time. So how long ago did people suddenly start saying, actually, this is the thing with regards to climate?
Yeah, so for me, it's been about 6 years, but when I started looking into it, there have been papers that were put out over 10 years ago now looking at this. And in fact, Jody Sherman at Yale is one of the pioneers in this field, and she published a life cycle assessment looking at our inhaled anesthetics and comparing them to alternatives that are given in an intravenous form. So comparing these inhaled anesthetics to one another, as well as to alternatives in the IV form. That was published in 2012. So this has really been known, for quite some time. That these are potent greenhouse gases. Some are also ozone depleters, and they can persist in the environment for a very long time. Nitrous oxide, which is also used in anesthesia, as well as in sedation outside of the operating room, has a lifespan of over 100 years. So it's persisting in the environment, acting as a greenhouse gas and depleting the ozone for about 114 years.
That's incredible. And again, it's that educational piece that's really important, isn't it? Because one thing is to actually go and then actually have mechanisms to address it. But the first thing is to understand the scope of the problem. And I think to be able to communicate that to the audience and to the wider audience is really, really important. So how have you gone about solving this problem? What's been your mechanism?
Yeah, so I think absolutely you're right that understanding that it is a problem is the first step. So that education component and, bringing this into medical school education and into residency training is really, really critical. But then also, understanding the scope of the problem and how we all play into it. And so that's where, help from our sustainability colleagues came in. And Dan, if you want to show the greenhouse gas inventory that was done by our sustainability manager, Colleen Grohl, in 2018. This is something that was done every year, but this is the first time I saw it. And she showed me this. This was for our entire hospital at Seattle Children's, our scope 1 and 2 emissions here. And so what she showed me was that after natural gas for our steam boilers and in our kitchens and commuting, anesthesia gases were the 3rd largest source of emissions from our entire hospital operations, not just the operating room, but the entire hospital operations. So understanding the scope of this problem, I think, is one of the first steps. And then understanding that we can make choices about how we deliver and use these anesthetics that will significantly impact the amount of emissions that we put out. So I mentioned, the last slide, that desflurane was one of the most potent greenhouse gases. So it has a global warming potential of 100 years compared to carbon dioxide of 2,540. So that means it is that many times stronger at warming the planet than carbon dioxide kilogram for kilogram. So that's obviously a really bad choice to use. And we have alternatives that are safe and effective and don't really impact patient care whatsoever. So the ASA and other organizations have recommended really moving away from desflurane and even nitrous oxide, because those are the 2 stronger greenhouse gases, and using other agents instead that have lower global warming potentials, or even using IV anesthetics that are much, much better for the environment and actually maybe even better in certain circumstances for patient care. So these are choices that we can make as institutions and as individual clinicians to choose a lower impact anesthetic.
Be fascinated to know of the people watching whether they've seen their own hospital admissions pie charts, if they exist. So the first thing is I'm wondering whether the clinical organizations where people are watching, first of all, do this kind of assessment. I think most do now because it's mandated to due to ESG. But how many clinicians or care providers or frontline staff actually get to see it and then get to scrutinize it? So I think that would be a fascinating first step to really understanding everyone's own environments in which they're working.
Yeah, I think Seattle Children's Hospital is definitely a leader in this field. We've had a sustainability manager. Now we have a sustainability director for many years, and we've made a commitment to deliver carbon neutral care by 2025. So we're getting really close to that. And I think that, many other hospitals are behind, but catching up. I think this is something that is on people's minds. People care about this. People worry about the health of their children and in their communities. That's being impacted by global warming, by the climate crisis, by wildfire smoke that's exacerbated by the climate crisis. So this is something that a lot of people care about. And I think as we learn the impact of healthcare delivery on the climate crisis and see, these kinds of reports, that this is a significant part of our emissions as a hospital, is our anesthesia gases. This is becoming something that people really do want to know, and they want to do something about it.
This is fantastic. So you found the problem, you looked at the pie chart, you said, this is an area of control that you had, this is operating theatres, this is something that is significant. How did you go about solving the problem? What did you do? Yeah,
so the education and socialization piece, I think, came first. So when I saw this pie chart, I began really talking about it with my colleagues and saying, hey, we should stop using desflurane. It's really, really bad, and sharing this information. And, same thing with nitrous oxide. When I was in training, that was the standard. We turned on nitrous oxide for almost every patient that we had. So we didn't, we learned that we didn't need to do that. We could really move away and use alternatives. The other things that you can do are utilize the gases more efficiently and less wastefully. So there are a lot of strategies to do that. So turning down your fresh gas flows, and this is getting into a little bit of the nitty gritty here, but there are certain things that we can do as we deliver anesthesia that still deliver the same amount of anesthesia to the patient, but waste less of these potent greenhouse gases. So we started to do that and provide constraints around that. And then really, I think the part we're here to talk about the most is the data feedback part. So we saw the 7% of our total hospital emissions, but that doesn't tell me how well I'm doing. So the choices that I'm making about, turning down my fresh gas flows, utilizing IV anesthesia over these inhaled gases when it's clinically appropriate and feasible, really paying attention to how I'm using my anesthetics and delivering care to patients. How is that making a difference? And so I worked together with Dan, who is the CMO of AdaptX, on this data feedback part. And I said, Dan, I really want to know how my emissions look, and all of these things that we're doing making a difference. And luckily, it's pretty easy to convert these inhaled anesthetic gas concentrations and fresh gas flow rates to carbon dioxide equivalents. The math has been out there for years, coming from Jody Sherman and other leaders in this field that have published this stuff and put together calculators that we can use to do those conversions. And basically, I told Dan about this and said, how can we do this at Seattle Children's so that we can see where we're doing a good job and where we still need to improve? And if I'm doing, if I should still tell people, this is how you should do it, is this actually better? So Dan, if you want to jump in here and explain kind of how we were able to do that together.
Yeah, no, it's amazing.
I think going on to that point, though, I think it's being able to explain the data and actually attribute data to individuals in an anonymized way is one of the very few ways I've found to be very, very effective at changing practice. Because as soon as you can see yourself versus the mean, it suddenly makes you reflect on what you're doing. So I think that point about how to change clinician's perspective or end user's perspective is a real art. So I'm curious to see how you did it.
I think it's fascinating. Rowland, a couple of minutes ago, you asked, I think, the exact question, how long have we known this is bad? And the answer is probably over 20 years. I mean, in 2000, I was training in Bristol in the UK, being taught how to use nitrous oxide combined with desflurane, and it's amazing. And oh yeah, it might be bad for the planet, but whatever. This is, and it was standard issue. It was, And so knowing something is bad and polluting and doing something about it are two very, very separate things. As Liz said, I'm so proud to have Liz as a colleague and a thought leader in this space, not just in our department, but now internationally, is she started getting inside people's heads. And it was like, can I just show you and tell you? And she was winning the hearts and minds battle, one at a time and making good progress. When we started unlocking the data, and this is what you're seeing happened over a 5-year period at Seattle Children's, we were producing about 1/3 of a kilogram of CO2 per minute per patient. Now you can just add that up over 30,000 cases a year. That's a tremendous, that's how you get to that 7% on the pie chart. That is an incredible amount of CO2 we're just generating, and it's invisible. It's like, there's no consequence. It's like throwing garbage in the ocean. Like you just, it's gone, it's out of mind. No one thinks about it until people like Liz started like telling people. And then what we started doing is measuring the data. This is the same chart. This is the same chart as we just. This is
fantastic, fantastic data.
The system. This is the same chart divided into 6-8 month timeframes, and these are people. To change a system, you have to change the people who do the work in the system. And so it's a hearts and minds battle, in this case of about 70 people. So now the problem becomes bite-sized. If we know that anesthesia gases is the biggest clinical contributor to any hospital's direct emissions, up to 40% sometimes for scope 1 emissions, that's been quoted. If we know that, it's not about changing 2,000 people in a hospital, it's about changing 50, 60, 70. And now it becomes a bite-sized problem. And when you talk about 70 people, these are individuals. And you can see over time how the people, these are the same people, improved. When you look back a few years ago, look at the variability in the system. Some people were producing 0.7 kilograms of CO2 per minute, and some people were producing 0.1. So, and we're all taking care of similar type of patients. It's the same hospital, the same department. So you had a 7x variance. As time goes on, and she talked about the education, the system constraints, and the direct data feedback. I'll do a case, 7 cases today, and it's like, how much CO2 did you emit yesterday, Dan? And now you have to own that. And that's really powerful. The data becomes a window into, did you harm the planet yesterday, or did you help the planet yesterday? And that direct feedback has been what's responsible for driving. You see how people are almost line dancing here. Liz, I don't know if you want to go into a bit more detail about these personas, because that's a fascinating story.
I think that's fascinating. And as you say, it's very difficult to influence what you can't measure. And to actually have that capability to feedback in near real time to end users about what they're doing on a day-by-day basis is incredibly impactful if you want to change practice. As I said, it's one of the few things I've found that actually really does make a difference. So super interesting data.
Yeah, absolutely. I mean, this to me is amazing, because all of our group can log in and see their data and the group's data. So we can all look at this chart and hover over each point and say, okay, this is me. This is how I've improved over time. And then, I send out monthly, now quarterly emails with this information. And I highlight those who have improved, those who are emitting really, really low CO2 emissions for their cases, CO2 equivalents for their cases, and ask them, how did you do this? What are your tips? We can learn from you. So, you're doing a great job here. Share with the group how you did that. And then I publicize that and really.
I love that. I love that. Learning from excellence rather than learning from failure is a really potent way, again, to try and get that change management. So the fact that you're pointing out what people are doing well rather than people are doing badly is great.
Yeah, and then the other thing, I think with this graph, seeing that, like anesthesiologist B was somebody who really used a lot of nitrous oxide initially, and we did some education and it came down, but they were still, one of the outliers and pretty high in terms of their emissions. And then put in some constraints and really, I think, changed the culture of the department. And then they became average, and now they're, really, really low along with everybody else. And so, that person needed a couple of nudges, but then is now completely on board with this plan. Anesthesiologist C is someone who has always used a lot of IV anesthesia, which I mentioned at the beginning was one of our more environmentally friendly choices. But in pediatric anesthesia, we don't often put IVs in our patients awake. So we still go to sleep using these anesthesia gases, nitrous oxide and sevoflurane that are, as I mentioned, both those greenhouse gases. And so that going to sleep part, you can do that in a high emissions way with high flows and lots of nitrous oxide, or you can do it in a low emissions way with lower flows and without nitrous oxide. And you basically achieve the same thing. It's just a matter of style and how people have trained. And once that IV is in, then you can turn it all off and think, I'm doing a great job. I'm giving an IV anesthetic. So that's what anesthesiologist C was doing until they learned, oh, that first 5 minutes of the case can actually be 90% of my total emissions for this case. And so I need to change those first 5 minutes. Even though I'm doing these IV anesthetics for the remainder of the case, it doesn't actually matter if I'm doing a lot of nitrous oxide and high flows at the beginning. So that education part really kicked in for them. And now, they know their data and they know they're the lowest emitter basically in our group because they've changed that first 5 minutes, that style that they did at the beginning. So they were already on board with the rest of it. And then
there's one thing, if there's one thing I know about care providers, that they're competitive. And if you tell them they're only average, they'll do their best, and there's data involved, they'll do their best to become even better. So I think
especially when they thought they were doing really well, and then they are confronted with the reality that, no, actually, there's a lot of room for improvement for you here. And here's how to do it, the steps that you take. And then anesthesiologist A is, really old school, like doesn't really buy into this at all. And so the education didn't really move the needle whatsoever. The practice constraints even didn't change much, but with the data feedback and additional practice constraints, and then I think some peer pressure, we got that person down 50%. So there's still a huge outlier, but still made a massive improvement and is now, below average compared to our baseline. So that peer pressure, and like you said, that competitiveness, even though they would never admit that this is what they're doing, they don't buy into this, but just going along with the group and some of those practice constraints and seeing, okay, I'm actually an outlier here, made them change.
That's an amazing story in itself. Rowland, I think about a rising tide lifts all boats, and vice versa, right? So here, anesthesiologists are still, a significant outlier in the last 12 months of data. But if you teleport them back in time and follow my cursor back, they would have been here. They would have been heralded as one of the superstars, like champions. So the least engaged person would have been one of the best people just a short time ago.
That's really interesting. And obviously there's a amount of anesthesia gases which are going to be consumed just due to clinical practice, but presumably there may also just be a system effect as well, in terms of that the system is not perfect in terms of all the tubes and pipes that link the anesthetic gases to the patients. So then is there a way to also capture just the system effectiveness in a perfect environment if the minimum amount of gas is used during anesthesia itself?
Yeah, so we actually compare. So this is the data, what the previous slide is the data that we're measuring, usage in the operating room. But what you were talking about is the purchasing data, right? And that's what we started with. That 7% was based on purchasing data, because that's what our sustainability manager had access to, right? So just looking at how many pounds of nitrous oxide did we buy from our medical gas supplier, and how many bottles of desflurane, sevoflurane, and isoflurane did we buy through our pharmacy, and then assuming that we used all of it, what was our emissions? But what we found once we had the data with AdaptX and we were able to measure it in the operating rooms is that what we bought and what we used are actually very, very different. And so that's what this graph is showing. This is just our annual totals. So what we're measuring in the operating rooms with our actual usage is in maroon there. And then our purchasing data for each of these gases is in the bar chart. So massive difference with our nitrous oxide, which is in the blue there. And this is something that that we noticed with this data. And I thought, okay, well, maybe this is explained by the non-anesthesiologist users of nitrous oxide that are outside of the operating room. So we're not capturing that data with AdaptX, because these folks are in the emergency department. There are mobile sedation nurses. They're in the dentist clinic. So I reached out to all those groups and did education with them and talked to them about, the effect of nitrous oxide on the environment and asked them about their practice and, looked for ways to reduce the harm there. And what I found was actually that they were not using nitrous oxide that much. And this was not explaining this huge discrepancy that we saw. And so I started asking around, connecting with some of my sustainability colleagues around the world, and eventually saw that some publications were coming out that the nitrous oxide system itself, the centrally piped supply in hospitals, is notoriously leaky. And so it's not the fault of our, buildings and engineering folks. They do a check every year. They do a great job, but the system itself inherently has leaks associated with it from the tanks that we use in our stock rooms, right? There is a regulator there that just off gases to prevent buildup of pressure. And so that's built into the system that there will be that amount of leaking that happens at each of the connections, the manifolds, the pipe fittings. It's really hard to keep something totally gas tight. We can think about plumbing, you can keep something watertight much more easily than you can keep something gas tight. And so this is just inherent in every system that has looked at this so far. They have found the same thing. There's a big gap between our clinical usage and our purchasing. So the solution here is actually to switch away from these centrally supplied piped nitrous oxide systems and use the portable tanks that we already have in many of our locations that can be closed completely in between uses. And this is estimated to reduce our nitrous oxide pollution by up to 95%. So this is something we're doing at Seattle Children's Hospital. Our sister hospital, Harborview Medical Center in Seattle, is also looking at that. They found that 17% of their total hospital emissions were coming from nitrous oxide alone. So they had a really big problem with their, and 95% was leaking, was not being used for patient care. So that was just totally unnecessary waste and pollution. So they're working.
That's incredible. That's a really amazing statistic. And again, how many hospitals that I've worked in, you've worked in, that have these pipe systems around the institutions where that invisible harm is not being seen? That's fascinating. And so it's an amazing result. Being able to reduce those gas emissions by 95% is incredible. And then on top of the optimized usage. So, is it all fixed? Is it, how, have you done everything you need to do, or are there more opportunities to further improve what you've already done?
Well, we're really proud of our team at Seattle Children's Hospital. We have achieved a massive reduction here. We're seeing a 10x reduction from where we started at baseline. So I'm super proud of our team. We've done a great job, but we're competitive, we're perfectionists, right? We want to do better all the time. So we're still looking for ways to improve. And one of the things that we're doing is also sharing our knowledge and these tools with other hospitals. So we've formed a consortium of pediatric children's hospitals that want to do similar work, and we're getting them on board, and we're starting to see their results coming in as well, with using the same kinds of socialization, education, practice constraints, direct data feedback, and working within their groups to see how we can achieve, similar kinds of reductions. So that's going on, internationally. And then we're also working on, because we've gotten some interest from adult hospitals who want to do this as well. And so we're working on a consortium for adult hospitals as well. So we're definitely spreading the word, and we still have a ton of work to do. But even at Seattle Children's Hospital, we still look at this data. We still try to see the areas where we can improve. And Dan, I know you have something to say about that too.
We can show. I want to just riff on what Liz was talking about. Let's just zoom out. When we take the whole system, including the ambulatory surgery center at Seattle Children's, we were, 5 years ago, we're at 0.5, half a kilogram per minute of CO2 per patient, and now we're at 0.04. So it's slightly more than 10x. That took 5 years. The consortium that Liz put together, because the adage, if you want to go far, go together, right? So she formed a consortium of, I think, 10 or 11 hospitals around the world, most of them in the US, but we have one in Australia, we have one in British Columbia joining. I'm going to just brag about our friends at Children's Colorado. It didn't take them 5 years. In 10 weeks, they achieved a 50% reduction, because we have the steps, and we know the playbook, and we have the data. So if you do all the things that Liz did over 5 years, and you do them all at once, you can get a 50% reduction in 10 weeks. We just saw our friends, Dr. Allen's group over in Akron, 30 days. She's the next hospital, a 50% reduction. So the thing can snowball. We don't need to wait 5 years. This is something that we can do in a month or two.
That's incredible. You're hitting all the right metrics because the finance directors are going to like it because it's going to be cheaper. The planet will like it because it's just better for the environment, and it's non-inferior to current treatments. So patients patients don't know the difference.
Yeah.
And I think it's absolutely incredible. Looking at that decline and those cost savings and carbon offset is really impressive.
So if I want to take you right down to here, let's bring you up to the current date. So I actually want to go into a live system and show you that.
Well, I was going to ask that. I'd be fascinated to see it. And again, I'm sure the people watching this will be really interested to see what this thing looks like in real life, because often technology is considered far too complex. You know, do you have to write code to be able to do this? You know, it's fine in principle, but how do you actually deploy something like this in 30 days? Is it real?
Yeah.
You know,
So let's jump into a live system and say, how are we doing in the last 6 months? So we're in AdaptX right now. We'll jump into the OR environment. I'll just pull up, and this is how easy it is. I can just pull up the last 6 months of data coming out of this hospital, and let's just pick the main hospital, and you know, you can see in the last 6 months you've operated on 6,000 patients, and then you can surface, well, what's the metric here? So we have the clinical metrics for sure, but for the sustainability, we can look at CO2. So we can say, how are we doing the last 6 months? And you can see the work doesn't stop. We've actually improved again. So this last 3 months we're better. If I just split the cohort so you can see, hey, how are you doing in the last 3 months? You've now got this was April to July essentially. This is July to yesterday. We've had another 25% improvement in the last 3 months. We're improving at a pace. Now you might say, how are we driving that? And it comes down to the people and what the people are doing. So if I stratify that data by the people and the type of cases we're doing, we can look at it by people. If I look at it by the anesthesiologists who are responsible, I won't hover over names because you can see them. But
no, don't do that.
You see where my mouse is? You see there's 2 people really high up there, right? Those 2 people are now, they're down here. Those 2 individuals got, went from 0.14 down to 0.05. The one I'm hovering over here got 3 times better. The message eventually got through. This person got 5 times better in the last 3 months. And when you make those 2 people get better, the whole system improved by 25%. So I just went to Climate Week in New York City, and I met Gary Cohen, and he's on stage, and he says, this is now a hearts and minds battle. If you can move the whole system 25% by winning hearts and minds of 2 people, this is where we're at.
Fascinating. And as you're probably aware, that the COP28, which is going to be held at the end of the year in the Middle East, which is like the global sustainability conference, there is actually going to be a healthcare day at COP this year. And so there's so much interest in this area in particular around how healthcare can impact climate change. These data in real time, being able to see impact, is incredible. Now, I guess, so the question is, that's great. And you can see the real data in real time, but I'm sure there'll be a lot of people watching this going, so how do they get involved? What do they need to do to actually take the next step? Because if they want to be, like Colorado Children's and jump into it, what's their best way of accessing it?
Well, they can scan this QR code and come to our website to learn more and join our consortium. We're still recruiting for Project Spruce Forest, which is our pediatric consortium. We have our phase 1 underway, but we're recruiting for phase 2, so join us. And then Project Evergreen Forest is for our adult hospital colleagues. So if you're an anesthesiologist, you can be the clinician champion for this. But if you're not, if you're working at a hospital and you are, a sustainability person or whoever, you can connect with us anyway, and we can try to find a clinical champion, or if you have a clinical champion you can connect us with, we can work together to make this happen at your institution.
Fantastic. And it's really interesting to see that you had the pediatric anesthesia group set up originally. How come the Project Evergreen Forest was established? Was that kind of an organic movement saying, hey, why are the kids getting to benefit from this?
Yeah, I mean, I think, we initially thought, well, in pediatric anesthesia, we may be more polluting because we're doing these inhalation inductions. And those, as I mentioned, can be responsible for the majority of the emissions of a case, depending on how they're done. And so we thought, okay, let's target, these pediatric anesthesiologists because we're probably worse, in terms of our emissions than our adult colleagues. So we know how to do it because that's where we are. So we thought, let's share our expertise and our experience and recruit these, pediatric hospitals to join us. And we got interest from adult hospitals, and, a lot of pediatric hospitals have a sister hospital. Like we have the University of Washington and Harborview Medical Center as our sister institutions. That are adult hospitals. And so, every pediatric hospital usually has one of those as well. And so we were getting interest from those folks and turning them away initially, and thought, okay, we started looking at the data for the adult hospitals, and they're not that much better. They have a lot of work to do too. So we thought, okay, let's help them out too. Let's learn how we can do this in adult hospitals and bring those folks in and share with them what we have learned so that they can improve as well.
So when the viewers scan that QR code, what are they going to expect? So what's their journey to enrollment going to be? How easy is it to get on board?
So that website has a frequently asked questions section. You can see who's already joined. You can see links to resources, and then you'll be able to contact us through the website as well.
And
fantastic.
And one of the most important resources is you have a clinical champion at the hospital. I've got fire in my belly. I want to fix this. And on the website, there's a one-pager that you can take to the C-suite. And the one-pager summarizes, this is what we want to do. This is what has been successfully done, is what we want to do. We need your support from the leadership. This doesn't happen without leadership. And we want your support. Would you support this? And if you do, these are the resources we need to get this up and going. Because there is a technology play. We are so grateful to our AWS colleagues and the infrastructure you have built over the last decade plus to enable this. Without cloud computing, without that resource, none of this is possible. So we stand on top of your shoulders as well, Rowland, from your organization. So incredibly grateful for your support and AWS's sponsorship.
I think we're very committed to sustainability and climate, the impact on the climate, and that's why we are going to be using fully renewable energy for all of our infrastructure around the world by 2025. And so that in itself, where hospitals are moving away from running their own data centers and they're running more clinical systems in production, and also the back office things like finance and human resources applications, if they can run an infrastructure which is far more efficient in the first instance, because we know that running in the cloud is 3.7 times more efficient than the median US data center, and 5 times more efficient than the median European data center, by the way, that is a massive impact in both carbon offset as a system level, but also the fact they're using renewable energy is a really important thing for them. It sounds to me as though you really do need climate champions as well within your organizations. Do you think that's key in terms of identifying the right clinical champion in an institution that wants to take on this?
Yeah, we need an anesthesiologist champion for sure. I mean, that person is the one doing the education and socialization and sending out the direct data feedback to their team. But it can be just one person. You don't need a lot to make this work. And once you have AdaptX up and running, I mean, Dan just showed how easy it is to pull the data and create these reports. And that's all you really need to send out to your group. So you don't have to have, the anesthesiologist champion with any sort of technical expertise with computing or data analysis. It's very, very straightforward, very easy to use. So, that person can do all of that on their own. Once they have the software up and running and the support from the leadership to move forward.
Fantastic. Well, thank you both so much for a really interesting conversation. It's absolutely incredible the journey you've taken Seattle Children's on, and you are taking multiple organizations around the world on now. I think hats off to this work, and also the platform that's been built by AdaptX to allow this data to be surfaced, because I think that's a non-trivial task, but to make it easy and make it easy for end users is really important. So thank you both. And I'm sure that there'll be many questions coming from the audience, and I'm sure Daniel will be able to field them.
Thank you so much for hosting us, and thank you everybody and Becker's and AWS today. Thank you.
Yeah, thank you so much. It's been a pleasure. So I see a lot of really awesome questions in the Q&A. So I'm happy to go through those here. And yeah, I'll just go ahead and start with them. So thanks for having me here. I see Roberto de la Cruz wrote, why can't desflurane be simply removed or limited from the market? Are there clinical circumstances where it is required? That's a fantastic question. I think that some clinicians would argue they still do want it for very specific circumstances. At our institution, Seattle Children's, we no longer felt like we needed it. So we did remove it from formulary, but that was a decision that we made as a group. Our anesthesia group decided to do that. So I think that more and more places are going ahead and doing that. You may have heard about in the UK, it is being removed from use. So there are places where it is just being removed, but I think that's a process. And there are, some folks who still really want it. And of course, the manufacturers would like it to still be sold. So there is some, interest in keeping it around, but we have found that we are doing just fine without it. And a lot of other hospitals are doing the same. All right. And so then the next question is from John Culver. How was the gas consumption data retrieved? Is this based upon gas utilization at the patient spend data or something else? So fantastic question. We actually did both. So we have for years been tracking our purchasing data, and that is based on our total number of bottles that we purchase each year. So we get that from our pharmacy, and that's the purchasing data that we had been using. But what we found when we actually started tracking at the individual patient level was that discrepancy between what we purchased in terms of specifically nitrous oxide and what we were using. What we're using, we're able to capture using AdaptX software. So it's all data that we have in the EMR, our fresh gas flows and our end tidal concentrations of these gases. We're able to calculate our usage based on that. So we did both. And then Robert Gasselberti wrote, have you seen an increase in anesthesia drug cost after having implemented this program? So we are not specifically following that. There's a lot of factors that go into pharmacy costs with supply chain disruptions and drug shortages and changes to our formulary. So it's very difficult to actually track that in a way that would give us the real impact of what we're, to see if there actually is an impact from what we're doing in terms of our gas reduction. We are, I think, using more of the IV anesthetic options, but including propofol, which is the main IV anesthetic drug there. But what we did alongside that was implement some programs to reduce the amount of waste in our propofol usage. So calculating ahead of time, making an estimate of how much volume of the medication we would need, and then selecting that appropriate size vial. Some other groups have looked into the amount of propofol waste in a system, because people will open maybe a 50 ml bottle, but only use 35 mils of it or 20 mils of it, and then the rest is wasted. So there's estimates between around 50% of the propofol that's purchased isn't even used anyway. So I think with our efforts to reduce waste there, we've probably come out even, although I don't have the data to exactly say that. So that's a really good question. I think would be really interesting to follow up on in another study. All right, and then Stacy, correlation between CO2 emissions and patient anesthesia outcomes to be sure there are not negative outcomes for those with the largest reduction in CO2 emissions. Absolutely. This was really important for us to do. AdaptX makes it really easy for us to track what we call those balancing measures. So we are looking at all sorts of other metrics to ensure that we're still providing really high quality care to our patients. And so we can look at things like PACU length of stay, PACU nausea and vomiting rates, pain scores, other efficiency metrics, our family satisfaction scores, which is really important to us to make sure that we're still giving patients and families a really high quality experience. So those have not changed in a significant way, and we still see really, really high patient and family satisfaction scores. So that was something that we, from the beginning, decided was really important for us to follow. Let's see, practice constraints. I see that question on there. So practice constraints are things that we implement for our anesthesia groups so that people are sort of prompted to go in the direction that we want them to go. So some of that is really subtle, but some of it's more significant. So one of the practice constraints that we implemented was before we took desflurane off formulary, we took the desflurane vaporizers. So that's the equipment necessary to deliver desflurane in the operating room, and we moved them to our anesthesia workroom. And so people could still use desflurane, but they had to go and get the vaporizer or ask the anesthesia tech to go and get the vaporizer. So it added a little bit more work for them. And so it's a little bit of a constraint, but it's not as much of a constraint as when we took it off formulary. So those are the kinds of things we're talking about there. Another one was at our ambulatory surgery center, we unplugged all of the nitrous oxide hoses from the wall. So it's just an additional sort of cognitive aid reminder. We're not using nitrous oxide routinely. If you really need it, you can use it, but you do have to take this additional step to plug it back in. And another example was the default settings on our anesthesia machines. So when you turn on the machine, there are some settings that are programmable that our techs put in when we first got these machines, and one of them was the default fresh gas flow. So that's how much oxygen or flow is coming through the machine, and that directly impacts how much anesthesia gas we use. The higher the flow, the more gas you use. And so sometimes high flow is needed, but most of the time it's not. And so we reprogrammed the machines to lower fresh gas flows that were still enough and safe and efficient, but much less wasteful. So that's another constraint there. And all of these things, for the fresh gas flow, the clinician is always free to change it if it's needed to go up or down. So it's, there's some flexibility there. All right, so let's see, I'm just scrolling up the questions here. There's so many great questions. Contact, great. So yeah, feel free to email me and go to our website, projectspruceforest.com, and you can get in touch with us there. Yeah, so what's the timeline for bringing AdaptX into your system and training people to use it? So the training people to use it part is what I feel I can answer most effectively, and that is really fast. It is an incredibly intuitive software system, and most people can pick it up really quickly, especially, the basic analyses that we're doing for this. It doesn't take really any training at all. It's just a little bit of a demonstration, and then folks can kind of just run with it. Getting it into your system is a little bit trickier because you do need some IT work to get the data feed going, but once that's done, it's automatic. So we have seen, this go pretty quickly, like a couple of months, but some places there's just a little bit more resource allocation issues with getting the IT support for the initial onboarding, but it's pretty quick. All right, and then Mike Connolly has Seattle Children's Hospital Sustainability Champions use AdaptX to measure your recycling efforts. So PVC packaging, blue wrap, et cetera. That is a really great question. AdaptX is awesome at doing analyses with things that we already collect in the electronic medical record. And those kinds of things where we're using supplies, that's tracked really differently. And so it's a little bit harder to do. But we do have really awesome recycling champions in the operating room, and our sustainability team is fantastic. And we have a really robust recycling program. We do a lot of reusable materials in the operating room as much as we can. So but those things are a little bit more challenging to track. And so we haven't been able to do that in the same kind of systematic way that we have with the anesthesia gases. All right, and then let's see, have you made any adjustments to your fleet of anesthesia machines to leverage the machine's technology and ability to enhance the practice of minimal flow and low flow anesthesia and collect data from the machine? Yeah, so that's a fantastic question. It's really important to recognize that some of the anesthesia machines have features that make this kind of work really, really easy. So we upgraded our anesthesia machines before we started this work to machines that allow us to do a lot of these things. So we do have a flow wizard that tells us how efficient we are with our fresh gas flow and calculates our leak for us automatically so that we can turn our flows down as low as possible. It also takes our gas sampling line and returns it back to the machine so that we are not wasting any fresh gas flow at all for our sampling. And oh, excuse me, I'm sorry. Can I use this room for just a little bit longer?
Sure,
thank you. Great. And then there's a question about measuring the amount of anesthesia gas left in the atmosphere by the gas scavenging system. Oh, this is a really interesting question. So yes, especially with pediatric anesthesia, when we're doing inhalation inductions, there is some amount of leaking around. If you have a patient who's moving, you may waste some anesthesia gas through leaking at that point. And that's really hard to measure. I think what we would say is our surrogate there is, again, comparing the purchasing data to our measured data from the anesthesia machine and from the electronic medical record. So with our volatiles, our sevoflurane that we use for inhalation inductions, we do not see a big gap there. So I think that most of the gas that we're using, we're actually capturing in this system with AdaptX, and we're measuring. Where we do see the big gap is with the nitrous. And again, that is, that's the system-wide leak. So that's not the leaks that we're seeing with the mask and with the machine. That's a really interesting question. And then I see a question about the cost for AdaptX. So for our pediatric consortium project Spruce Forest, it's $20,000 per year for the software. And then for the adult facilities, $20,000 per year. And let's see, and time. So the time is, we need a clinical champion. So you need someone who's going to be responsible for the education, the socialization part of things, putting together the reports and giving the feedback to the teams. That takes, once you get up and running, a few hours a month. It's really minimal time commitment once you get going. In terms of the IT investment, we've estimated it's about 35 hours of IT work to get the data streams going. Although I think we're probably getting a little faster with this. The more hospitals we have online, we're able to share our experiences and knowledge so that the next group gets it done a little bit faster with tips and advice we've gotten from the previous group. So that may be a little bit less now, but there is some upfront time commitment for sure from the IT folks. And let's see, let me just make sure I didn't miss any questions here. Yeah, I think lots of people saying we can hear you. Thank you. I can't see myself or see any of you, so speaking a little into the void. Oh, there's a question I missed. Was your facility using cryogenic containers on your manifolds at some point when you were assessing the leakage? So I think this is probably in reference to nitrous oxide. So there are different tanks that nitrous oxide can be supplied in. So there are cryo tanks that are usually used in the central supply area, the central kind of stock room, and then the pipes come out of that and apply to the rest of the hospital. And those ones have a pressure release valve that's required for safety so that it doesn't overpressure, but that pressure release valve is, has some leak associated with it. The alternative to that system is e-cylinders that can be on the back of the anesthesia machine that can be closed in between uses. Those are not cryo tanks. Those are just regular medical gas e-cylinders that do not have leaks associated with them. So that is the much more effective way of delivering nitrous oxide without having these massive infrastructure waste. So that we currently still have the cryo tanks, and we are working on transitioning our system over to the tanks that we can close in between. But that is actually quite a process involving making a lot of policy updates and involving the Department of Health to get their approval in the state of Washington. That is required for us. So there are many steps that have to happen before we can completely abandon that old system and use the e-cylinders. And then I think there was one new question. What role can facility teams take to help streamline this transition for individual hospitals? Do central systems need to be decommissioned? So yes, they do. I think this is one of the most important ways to reduce the amount of greenhouse gases that we are emitting as hospitals that it has no impact on clinical care. So this amount of waste that we see with these leaky nitrous oxide systems, none of that nitrous oxide is being used for clinical care. So we can still use this medication when it's needed for clinical care, but we can eliminate the waste that comes with these central supply systems. So I think that's really important. But yes, you do need the facility management team to be involved. You need, folks to be championing this along with the anesthesia folks who may be leading the clinical side of the work. And then, yeah, has your group looked into the harm by the other gases used in the hospital other than anesthetic gases? So that's a really interesting question. There are a lot of resources out there for ways that hospitals can reduce the environmental impact of delivering care. And one example of that is metered dose inhalers. So there are propellants in metered dose inhalers that are really potent greenhouse gases. And so what we have been told from other sustainability leaders is that using nebulizers instead of metered dose inhalers when possible is one way to significantly reduce the environmental impact from those. And again, no impact on clinical care because you can still deliver the inhaled medication. So that's one example that I can think of off the top of my head. And then I think maybe I got all the questions here. Any more questions? Oh, yes, I do think that this is going to be recorded. See that question on there. Yeah, and then are there ways to track the anesthetic gas leak impact on employee health? That is a fabulous question. I know for us at our hospital, we did a program where we had sensors on a lot of our staff and we could evaluate their exposure to our inhaled anesthetics when they were part of the team caring for a patient. So we did that. It's pretty resource intensive. You have to have these sensors, you have to have the machines that can analyze the exposure. So it's not something that we do all the time, the way we do with, for example, like radiation safety and radiation exposure, but it's something that we have done in the past and we were able to identify workflows in areas where there was higher exposure and do some work to reduce the impact there and the exposure to staff. But other than that, I'm not entirely sure of other ways to track that. And then question from Mike Connolly, have you seen an increase in regional anesthesia versus GA since you began this project, both for adults and peds? So really good question. There's some really fascinating work coming out of Australia. They've done some life cycle assessments looking at the total environmental impact of regional anesthetic versus general anesthetic, and there's so many different factors that go into it. So that's a whole line of research there. At Seattle Children's Hospital, we have a really robust and strong regional anesthesia program, but in most cases for pediatric anesthesia, we are combining regional anesthesia with general anesthesia because they're kids and it's hard for them to just have a block and no sedation or not general anesthesia along with it. So we have had a really robust, strong regional anesthesia program for years. So I don't think that we've seen a change there, but I do think that using regional anesthesia is a really great way to provide a good patient experience, potentially reduce the amount of general anesthesia or medications that are needed, reducing opioids, all sorts of things. So that's it's a really great line of thinking there. And I see a joke there about leaky nitrous oxide systems leading to happy hospitals. So yeah, I mean, it's something that I worry about with our, leaking systems, that there are staff potentially who are working, maintenance staff who are working in these supply rooms where we have those tanks and they may be exposed to nitrous oxide and not realize it. And we can joke about how it might make them feel giggly and silly, but there are real health risks to chronic exposure to nitrous oxide. And I think that, that's one of the very important reasons that we need to look at this really critically and abandon these leaky systems. All right, and then I just see a comment here, no more questions. So, all right, I think that unless there is another question that pops up in the chat here, we're gonna wrap it up. I appreciate everybody's interactive, questions and comments in the Q&A, and really appreciate being able to participate in this. Thanks to Becker's and AWS and AdaptX. Really excited. Thanks, everyone.